All right, good morning or good afternoon, everyone. I'm going to go ahead and just get started. My name is Lavette Shirley, and I am one of the co-founders of the Women's Health and Resilience Foundation. We're expecting a few more people, and just as they trickle in, I'll just let them in, but we'll go ahead and get started. But the Women's Health and Resilience Foundation is a nonprofit organization founded in 2024. And we are focused on just taking kind of a holistic view of women's health. So where can we find ways to support women? One of those ways is, very close to my heart. It's something that most women do at some point in their lives, especially as they get older, have some difficulties with, and that is, pelvic floor health. So I'm excited about our session today. Our history is founded on just finding ways that we can support women in globally. So whether it's, health literacy and understanding our bodies better, understanding medicine better, bridging the gap between providers and patients, we want to, just kind of fill that gap and help women just to have better outcomes because they are, more educated about their own personal health. So today we have a special guest with us for the kickoff of our Lunch and Learn virtual sessions. And this is Dr. Anna Karim. So she is the founder of the Queen City Pelvic PT in Charlotte. So she has 30 years of experience. Give me one second. Perfect. 30 years of experience and specializes in pelvic health, sexual wellness, postpartum recovery, pelvic rehabilitation, integrating physical therapy, yoga therapy, and trauma-informed care to support whole person healing. So that's very mission aligned with the Women's Health and Resilience Foundation. So she is recognized as a leader in pelvic health education and advocacy. So without further ado, I want to introduce to you guys Dr. Anna Karim.
Hi there. I'm really happy to be here with you all today. I'm going to share my screen. So I have a short presentation, and then we'll have time for Q&A at the end. So let me share my screen. I've already practiced this, so let me make sure I can do it. Okay, so I love this emoji. I laughed so hard, tears ran down my legs, implying that we're peeing on ourselves. And we're going to talk a little bit more about that. We think it's funny. And yet, when somebody tells me that they're leaking when they're laughing, I'm like, oh, you need to come see me because you shouldn't be leaking. So, we're going to, in this slide, talk about understanding the pelvic floor issues and restoring quality of life with physical therapy. Oh, I want to go to the next screen. Hold on just a second. Here we go. So first I wanted to start off with a little bit of anatomy. On the image on the right, this is if I were to cut us in half and we were looking from sideways in. So the pelvic floor is the unsung core hero, but it's just one part of the core. So the core includes your diaphragm, abdominal muscles, your back muscles, and then the pelvic floor muscles. And the pelvic floor muscles are like a 3D muscular hammock that spans from your tailbone, so your tailbone, all the way to your pubic bone, and it supports your bladder, the uterus, and the bowel. And it has four essential functions. I like to use an acronym or the shortcut of saying it has four S's. One is for stability and support, particularly with your posture, but also to support the organs. Sphincteric, meaning it helps close the openings that support bowel and bladder control. It works as a sump pump, so it helps to pump up blood and lymph. So it's constantly pumping to get fluids back up towards the heart. And then finally, sexual function. The pelvic floor is constantly at work. It engages every time you breathe, you walk, you carry groceries, lift kids, or laugh. And I like this image here on the left because it shows this hammock quality. So the pelvic floor muscles are supporting the bladder in the front, the uterus, and then the rectum. And it has to help manage the pressure that's coming from up above. This picture on the right is an anatomical view of the pelvic bones, the pubic bones here in the front, and then the hip bone. So you can see that it's a 3D kind of diaphragm that has a lot of function, although these muscles are very tiny. But they also interplay a lot with musculature that goes to the hips. So, according to research, nearly 1 in 4 adult women is experiencing at least one pelvic floor disorder. I've seen statistics showing that 1 in 3 women have urinary incontinence. So the next time you go into a room, look around. A third of the folks in the room are experiencing probably incontinence, and then a quarter of the women in that room are having some type of pelvic floor dysfunction. And so it is common, but what I always want to tell folks that it's not normal. So this morning I had a call with a potential client, and she called me because she's preparing for surgery. She's having a hysterectomy. And I said, so are you having any other issues with pelvic floor that you want to see me beforehand? She goes, no, I don't. I said, any issues with leaking, with bowel issues? She goes, oh, well, oh, yeah. I mean, I leak. I've leaked ever since I've had my children, but that's normal. I mean, I just consider that normal. And I said, oh, no, it's not normal. It's common, but not normal. And it's something she doesn't have to live with. The prevalence of pelvic floor dysfunction then increases 40% for women aged 60 and older. However, we think that people are underreporting and it remains high, probably due to embarrassment or assuming it's an inevitable situation or a part of motherhood or aging. So here are some of the common pelvic floor disorders that I treat. These are most common. I certainly treat a lot of other issues, but the big ones are urinary incontinence, and there are a couple of types, main types: stress urinary incontinence. This is when you leak when you're laughing, coughing, sneezing, jumping, heavy lifting. Urge incontinence is the type of leaking that happens when you have a sudden urge to pee and you can't get to the bathroom in time. And here you see I wrote key indoor. Typically, I have folks who say, as soon as I see the front door or as soon as I put the key in the door, I have a sudden urge and I cannot stop it. Some people will tell me if they hear running water, that will happen. I had one woman who would pull into the parking lot of her apartment complex. As soon as she pulled in, that urge would kick in. Mixed urinary is a combination of both stress and urge incontinence. Pain with sex, it's called dyspareunia. And there can be superficial dyspareunia or there can be deep dyspareunia. So I always try to understand, is the pain with sex or any type of penetration? It could be using a vibrator. It could be using a tampon, or for some of my women, it's just that they can't even tolerate the speculum at the gynecologist's office. So pain with entry and pain with deeper penetration. Typically, this is related to tightness or overly active pelvic floor muscles. They can be spasming, not just weak. Folks will describe this as burning, aching, or sharp during or after intimacy, and it can be linked to a variety of issues. Some of them here are included anxiety, a history of trauma, and trauma can be not only sexual trauma, but it can also be medical trauma or a traumatic birth delivery. Scarring, and as we get older, hormonal shifts. Though I am seeing some younger women who are having, they're also having some hormonal shifts because they've been on birth control pills for a long time, and they will have some pain at entry. The other condition is pelvic organ prolapse. And this is where you have heaviness and pressure in the vaginal area. It feels like something is falling out or falling down, or you might feel a bulge. If it's the bladder, it's called a cystocele. If it's the bowel, it's called a rectocele. But we can also have uterine prolapse. The drop is usually due to ligamentous or muscle slack. That's the ligaments and the connective tissue that hold up those organs have gotten really stretched out. This is made worse by chronic straining, constipation, heavy lifting with poor technique. And sometimes we see this, the risk increases with multiple births, vaginal births. And then I also treat a lot of folks with low back, hip, and pelvic pain. When I evaluate someone, I'm just not looking just at their pelvis. I'm looking at the whole picture. I'm looking at their abdominal muscles, their back muscles, their hip muscles. And so pelvic floor muscles work in coordination with all the other muscles. So sometimes if somebody's having hip pain, it's because it's their pelvic floor referring out to their hip and vice versa. So these are the most common conditions that I'll treat. Typically, pelvic floor issues fall into two broad categories. And I'm simplifying here, but almost often we're looking at, are pelvic floor muscles weak or are they tight and overactive? And even tight and overactive muscles can still be weak. So that's often a little bit confusing, but at its simplest, we're looking at, is there just a lot of weakness? And then do we need to work on strength? Or is there a lot of tightness and hyperactivity? And we need to work on lengthening, stretching, and then we'll work on the strengthening. So some common factors that can contribute. And these are just a few. Pregnancy and childbirth, so carrying the weight for 9 months stretches the pelvic sling and that pelvic hammock, whether vaginal delivery or C-section. Multiple births increase risks of pelvic floor dysfunctions. That doesn't mean every woman who's had multiple babies will have issues, but we've seen that multiple births do increase some risks. Repetitive strain and straining. So heavy lifting type jobs, chronic constipation or pushing on the toilet, chronic coughing with asthma or smoking. And then we see changes with hormones and aging. So estrogen reduction during perimenopause and menopause changes tissue collagen and also muscle tone. I'd love to hear from some of you if you're interested in sharing. Do you talk about pelvic health issues with anyone, and why or why not? I don't know if anybody wants to share just a moment. So I'll tell you, a lot of folks don't share because it's taboo. We just don't talk about our pelvic floor. I also think it's getting much, much better, but in medical offices, sometimes it's not being talked about. And sometimes there's not even just a simple question like, are you having any urinary issues? Are you having any bowel issues? How is intercourse? Do you have any issues with that? So I think the boom of social media has really opened up where people are at least hearing about pelvic floor issues. Most of the people who reach out to me, they have found me on their own because they saw something on social media and then they went to a Google search. And lately, even ChatGPT has been doing a good job at recommending that pelvic PT be utilized. So I think some people also don't talk about their pelvic health issues. One, they might think it's normal. Two, they might think it's embarrassing. Three, if they were raised in a culture where sex wasn't talked about, then they just may not feel like they know who to talk to. So part of my passion is trying to share more with my community. So a few myths I'd like to debunk. So myth one is just do 100 Kegels a day. The reality is that if the pelvic floor muscles are hypertonic or hyperactive or too tight, squeezing worsens the pain, may worsen urgency, and then over 50% of people perform unsupervised Kegels incorrectly. So there are some commercials out there about this chair you can sit on, and it gives an electric current, and you can do 50. It'll do 50,000 Kegels for you in 15 minutes. Well, first of all, no one needs to do that many Kegels. Secondly, nobody's assessing an individual to see if they actually have tight muscles or they have weak muscles. And so we may actually be doing more damage with that kind of passive pelvic floor exercising. And thirdly, it's passive. And so if a person never really figures out how to find those muscles correctly, as soon as they stop using the chair, if they don't keep it up, they're going to go back to their situation. Myth two, peeing when you sneeze is a normal badge of motherhood. The reality, it's common, but clinically it's abnormal muscle coordination and it responds really well to physical therapy. Myth three, surgery or diapers are my only option. The reality is the American College of Obstetrics and Gynecology guidelines explicitly endorse conservative physical therapy as the first line of clinical treatment before any invasive options, number one. And number two, there are so many other options, and we can get to not having to use Depends or pads. It may take us a moment to build some strength and some coordination, but folks, women should not feel like that's their only option. So what is pelvic PT? So pelvic PT is a specialized subset of physical therapy, and it focuses primarily on the muscles, connective tissues, joints, and the nerves located between the belly and the knees. My elevator spiel is, I'll say, I'm a physical therapist who works and addresses and assesses the whole body, but I tend to focus on the muscles and all these other parts of our body between the belly button and the knees and 360 degrees. So that's usually my spiel, just to give folks an idea of the area we focus on. How does pelvic PT help? So we can use a variety of minimally invasive strategies to help. This can include stretching and or strengthening exercises. So remember, if somebody is tight or they're presenting as their muscles are already really clenchy and they're having pain, our first goal is to learn how to lengthen those muscles, how to get some gentle stretching, learning how to breathe so we can relax that pelvic floor muscle set of muscles. And then once we've achieved that, I usually do start working on very specific type strengthening and coordination exercises. I utilize a software program. It's a biofeedback program, and I place a sensor on the pelvic floor, or we can use an internal sensor. And then my clients are able to see on the screen what they are or are not doing on their pelvic floor. And by using visual feedback, we can train the muscles to do what they need to do. Manual therapy. So this can involve external manual therapy, but often I'm doing internal. So I'm doing a vaginal insertion with a gloved hand, water-based lubricant, and I am specifically working on specific fibers of muscles to release tight or restricted areas. There's a lot of education that goes on, not only on the first visit, but all along. A lot of women don't know their anatomy. So once women understand their anatomy, they're like, oh, this is all making sense. And now I know how to find these muscles. We talk about lifestyle habits and patterns. So I'm looking at what fluids are people drinking? What foods are they drinking? Are they getting enough fiber? Are they really stressed out and they never take time to really calm their body down? Are they sitting in postures at their workstation that are not good for their pelvic floor? I'm taking a look at body mechanics with work and or exercise. So if somebody really loves burn boot camp or a CrossFit, I'll often ask them to show me what they're doing. And often we do some tweaking on their form because they're either not breathing properly or they're not maintaining good core stability. I might also use electrical stimulation either to reduce pain or to help the muscles wake up. And then other modalities that I sometimes use are dry needling, breathing exercise. I'm also trained in fitting individuals for pessaries. So that's a type of ring or a cube or a disc that is inserted vaginally to support a woman's organs. So if they are not ready for surgery or don't quite need surgery, a pessary is an option to help give them support that their muscles are not giving them already. So what to expect on a first visit? I always do a lengthy review of a person's medical history, their lifestyle habits, their concerns, and their goals. I always do an orthopedic screening and a postural assessment. So I want to look at the whole picture first. And then I'll do a pelvic floor muscle assessment, and I'll do that externally for sure, and then internally, depending on the client's comfort and their consent. So what's really awesome is that we see that there's evidence for improvement through using conservative pelvic physical therapy. So we can see that stress urinary incontinence either totally improves, like we cure it, or we have significant improvement, 70, 85%. Pelvic pain and dyspareunia symptom relief, we can see an 80% increase in improvement. Prolapse stage and symptom reduction, 75%. And I do make a caveat here that that's if someone has in the lower prolapses are graded on a scale from 0 to 4. So we've seen a lot of evidence showing that with grade 2 and lower, pelvic PT is absolutely helpful. Grade 3 and 4 gets a little bit more challenging, but we still see some improvements. And then low back and pelvic girdle pain improvement, we see 88% improvement. I'd like to just share some simple daily habits that everyone would benefit from. So bathroom habits. I'm always talking about bathroom habits. I want folks to stop toilet straining. Stop straining to pee. Don't push your pee out. Don't strain to have a bowel movement. Instead, we want to relax on the toilet. And if we have to bear down, we want to make sure that we're breathing out as we gently bear down, not holding our breath and pushing, because that puts a lot of pressure on those organs. Hydration, eating fiber. Most people aren't drinking enough fluid. I tell folks, take your body weight, divide it in half. That's roughly about how many ounces of fluid you should be drinking a day, and probably 2/3 of that should be water. And considering reducing irritants like alcohol, sodas, caffeine, citric and acidic foods or drinks. Eating fiber, this is so important for stool formation. The combination of hydration and fiber really helps form your stool and get it moving so that you don't have to strain. I recommend using something like a squatty potty so that your knees are elevated. It improves the angle of your pelvis and the rectum, and helps you relax your pelvic floor. I also talk a lot about avoid just in case peeing. This means every time you see a bathroom, you say, oh, let me go just in case. By doing that, we really train the bladder and the brain to have to go more frequently. And then the other thing I really work on is relaxation strategies, particularly for my folks who have a hyperactive pelvic floor. So we work on 360-degree breathing. So we're breathing into the whole rib cage, not just the belly, not just the chest, but we're breathing into the low back ribs as well. That helps relax the pelvic floor. I love if women, but anybody would take 10 to 15 minutes a day just to relax or stretch, get off the phone, um, make some time for a hobby, journaling, some other activity which can help, generally speaking, lower kind of our nervous system that's always kind of on the go. And then my favorite little mantra that I share with folks is when you cough, laugh, lift, or sneeze, do a little squeeze. So sometimes it's not that simple, but I do try to help folks learn how to coordinate when they're doing these high pressure activities, how to engage the pelvic floor so that we're maintaining the support, but also maintaining continence. All right, so that was a quick little, let me see if I can escape here and come back to the screen. Oh no, did I lose us?
Still see you.
Oh, okay. Oh my goodness. Ooh, that scared me. Yeah. So open to some questions and some discussion.
Perfect. Well, I'll get started. I really appreciated the common does not equal normal, right? That's a conversation I feel like I have with patients regularly, that just because it's happened to, your mom, to grandma, it's happening to you, it's happening to your daughters, doesn't mean that's something that you have to deal with.
Yes,
So I love that there are some options that we're giving, and even thinking about some of the things that, we think of the big things, I think a lot of times when it comes to the pelvic floor. So I'm thinking about delivering, babies vaginally, especially if there's multiple babies, it just kind of makes sense. And that kind of, it makes sense that you'd have some pelvic floor discomfort issues, following that may need some assistance. But you don't think about the things like picking up something heavy, you don't think about things like having a chronic cough, which is a
yes.
big one, right? That's going to cause that pelvic floor over time because of strain and straining to weaken. So one of the questions that I have for you, because I know a lot of people worry about kind of going into these appointments and it's going to be uncomfortable, right? We're having somebody, checking out an area that we are not used to having, evaluated in this way. So when you're talking about like the electrical stimulation specifically, it helps with pain. Is it painful? What is that? Does that feel like? What is that experience like?
Sure. So I have done everything I utilize in my toolbox. I have tried on myself or had someone use for me so that I can know what it feels like. So electrical stim, typically we're using a sensor that's maybe the size of my finger, and it has three little electrodes on it. So this is just one option. And so you insert it internally. The internal sensor just has better contact with the pelvic bowl. And I always tell folks, we start off slow. They're in control, like they're pushing the button. And it typically feels like, for me, it feels like a bird is just slightly pecking me where it wouldn't normally peck me. So it just feels like a little bit of a vibration. Depending on how a woman's tissue is, particularly how well estrogenized it is, how much good estrogen it has. Some folks, and that's why I always test it in the clinic first, is that they say, oh, this feels like it's stinging a little bit. So then we work on, do we have enough lubricant on it? We change the position of the sensor. Most people tell me it just feels like a vibration. And if we get the sensor up high enough, the muscles will actually themselves contract. But rarely do I have many women who can tolerate taking it up high. My goal is for them just to have a sensation in the area that helps their brain know which muscles I'm actually trying to get them to isolate. So the way I teach E-stim is when you start to feel the electrical stimulation, I want you to try to pinch that sensor so that then they are now actively trying to do the pelvic floor strengthening themselves. For some women who cannot tolerate the internal, we can get very small electrodes that are just like not even an inch, they're half an inch by half an inch, and we can place them externally on the pelvic floor. And again, there feels kind of like a TENS unit, if any of you have ever used like a TENS unit, but it's just a vibration. If you take it high enough, it will make the muscles activate. But because we have so many nerve endings in the pelvic floor, most people cannot take it very high.
Thank you for that.
Yeah.
And just a question from Maya here. Thank you. Would you say the electrical stimulator is the same in the same realm as a spinal cord stimulator to help ease discomfort and disturb the pain frequencies that are traveling down extremities?
Sure. So that's a great question because I use eStem for two reasons. One is to help folks activate muscles, and I typically only use it on individuals who they just cannot find their pelvic floor. They cannot isolate them. And they're just getting frustrated with me saying, okay, tighten those muscles. They're like, I can't find them. So then I'll use eStem to help their brain kind of feel what that's feeling. In terms of pain management, we can use a different setting on the same device that I use. I use a different hertz level for pain management. So the goal there is the most basic way I explain it to my clients is I'm trying to send a different signal to your brain so that your brain isn't focusing on the pain signal. So it's almost as if, your elbow hurts, but I'm going to pinch your toe so that your brain is thinking about the toe and not the pain in your elbow. And again, there I'll use a different hertz level and maybe a different pulse width just to calm the pain signal.
Perfect. Thank you so much for explaining that. Another thing that I tend to see when I'm, as a provider referring to physical therapy is that, patients sometimes will say that it takes a lot of time and they have to come in often. So what does that look like as far as duration of time,
Sure.
and then how many days a week that they'd have to come in for something
Yeah.
like this?
So I'm private practice. I am considered out of network. And so it works a little bit differently with me. One, probably the longest somebody has to wait to get in for an initial assessment is 2 to 3 weeks. And so in North Carolina, number one, it's a direct access state. And so folks can reach out to me directly. I always want to know that they have a physician or a PA or a nurse practitioner, PCP. I want them to have a physician. If they're a complex patient, then I make contact with their physician because we need to be working together. What has worked for me now for 6 years is I typically see folks every 2 weeks. And part of that is because my philosophy is my goal is to start giving you a toolbox so that you understand your body and that you are an active participant in reaching your goals. So for the most part, that has worked. So on average, most of my clients, I'm seeing them every other week. 4 to 6 visits is kind of the average. Now, my pelvic pain, really complex clients, I might be seeing them once a week. And it really depends on all the factors, but it may be 3 or 4 months that I might see them, and then periodically as they need me. I always tell clients, if you're the type of person that I give you some education and some instruction and a home program, and you're like, I can do this, give me about 3 weeks, and then I'll come back in. We'll do that. And then I'll progress them when they come back. So it also really depends on the type of client. And because of my practice, I just have a lot of time to kind of figure that out and work with them. And I always want clients to feel like it's a collaborative decision, not that I'm dictating what they should do, because there are also socioeconomic factors.
Mhm.
What do their finances, how does that impact their ability to come to me regularly? Where do they live? I mean, I see folks from Rock Hill. I was seeing someone from border of Virginia. And so we would have an appointment once a month, but then I could do like a telehealth visit with them in between to problem solve and to talk through some things.
Oh, perfect. Yeah, that's nice to have that flexibility so you can
Mhm.
continue the care. That's
Yeah.
fantastic. Another thing that I was just kind of looking at your website is there's a lot of focus on like yoga
Mhm.
and pelvic floor health. Can you talk just a little bit about how yoga helps with the pelvic floor?
Sure. So in my present setting, I don't have room for like doing a large class. So it's very individualized. And I use a lot of restorative yoga, particularly with my clients who have an upregulated nervous system. So their stress management is challenged right now. They're not breathing well. They can't find that diaphragmatic breath. Um, so I'll do a lot of restorative yoga. So and I also have learned that I can't overwhelm clients with 20 exercises,
Mhm.
right? So I'll do 3 to 5 each session, and then we'll reassess which one can we drop or which one's not working for you, and then what do we need to add so that it just doesn't feel overwhelming. Folks who are really busy may or may not want an hour-long yoga practice, but if I can convince them to do 3 to 5 restorative yoga poses with bolsters and supports, then I can work on their breathing. I can work on their diaphragmatic movement. I can work on pelvic floor relaxation. We can calm the nervous system. For folks who are moving back into, let's say, postpartum, and they're moving back into strengthening, I like to use yoga as a slower version. It's a stepping stone to get toward back to your vinyasa flow, right? So too many times I see women really jump in postpartum back into like their CrossFit, their burn boot camp, their vinyasa flow, and their body has totally changed.
Mhm.
And so I like to do more like a hatha yoga or a yin yoga where we're really working on alignment first, stability before mobility, and then working through transitions with safe technique. And then once they are able to do that really well, then I'm like, okay, let's go to a slow flow, and then go to your vinyasa flow. Often what happens, sometimes it's because of finances and just time, is I tell folks my goal is to give you your foundation and make sure you are safely exercising and have the tools so that when you go to a vinyasa class, if you have any of these symptoms, you pee or poop on yourself, you have pelvic pressure or that prolapse symptom, you have pain, you're holding your breath, and you fall out of form. Those are your flags. If any of those flags raise up, then I want women primarily, I do work with some men, to feel empowered to modify even in the class, even if 20 other people are doing down dog with a leg up and like this is your yoga class.
Mhm.
You're feeling these symptoms, acknowledge the symptoms, and here are some modifications you can do. So I'll teach them modifications. Often folks will say, well, what exercises should I do and should I not do? And I'm like, there are a million exercises. We can't go through all of them. But if they know those 5 flags, the 3 Ps, I say, the pee or poop, the pressure, and the pain,
Mhm.
and then your breath control and your form. If you pay attention to those flags and you modify as needed, you'll be fine wherever you go.
Perfect. Thank you so much. And so
Mhm.
really my last question for me is, where can people find you? I did include, in the chat a link to your website, but
Right.
where can they find you and when should they reach out to you?
Sure. So I'm over just geographically, I'm over across the street from Park Road Shopping Center off of Park Road. And my website is queencitypelvicpt.com. And on there you can find a telephone number or an email. So most people reach out via phone or email. Um, there was one other part of that question.
And just when should they reach out to you?
When should they reach out? Well, definitely if you're peeing or pooping on yourself. um, that's common, not normal.
Mhm.
Um, I love to see people prenatally and postpartum for sure.
Mhm.
Um, if you're having any pain with any type of vaginal penetration, any pain, that's something we can help with, or I can direct you to gynecologist or practitioners who can help address the hormonal aspect, but then I can work on the muscles.
Well, thank you so much, Anne. This has
Yeah.
been fantastic.
Yeah.
My take-home message is because it's common does not mean that it is normal, and
Yeah.
I appreciate that.
Yes.
And we'll have this posted, and so people can review this
Right.
information and reach out to you when they need your support.
Perfect.
Also, just as a reminder, this is hosted by the Women's Health and Resilience Foundation, so you can find us at whrfoundation.org. And we do have a breast cancer awareness gala that's actually coming up on September the 19th. So please feel free to sign up for that. Reach out to us at Levette at whrfoundation.org with any of your questions. And thank you so much.
Right. Thank you. Have a great day.
Thanks.